Hi,
Hi.
Dr. Mariam. How are you?
I'm fine, Katerina. How are you doing?
I'm good too. Thank you.
How's
Yeah, we'll start in a few minutes. Pinging people in and sharing it on Twitter and waiting on Dr. Khalsa. So we'll start in a few minutes.
great? I'll be pinging some people in as well.
Thank you. Hi, Dr. Saif Khalsa. Thank you for coming. Uh, and we'll wait a few more minutes for giving people time to arrive. I'll also right, Dr. Olo. So I think he wanted to join. So let's wait for him to.
Sure. Can you hear me okay, Katerina?
Yes. Can you hear me? Well, everyone.
Yes.
Good. Great. Thank you.
Yeah, mic check for me too as well. Can you hear me?
Yeah. Yeah, we can hear you too. Hi, Christopher.
Oh,
Thanks for coming.
hi, hi. Thank you for bringing me up. I can't wait to talk about the topic because I have questions.
I hope I have answers.
Hi, Dr. Olo. Perfect. Thanks for coming.
Good to see you. How's everybody doing?
Good, good. Thank you. And you?
Hi, Dr. Olu. Hello, Dr. Khalsa, and I hope I pronounced that right. And hello, Christopher.
Hello.
Yeah. Hello. Hi, Olu.
Hey, Sabi. How's it going?
Pretty good.
Good, good.
Yeah, I think we can slowly start, and then we can always maybe let's just wait another minute, and then we'll start. Let me just share, like, finish pinging people in, and then we'll start. Just one more minute. Sorry. Okay, perfect. Let me so welcome everyone to the Science Society Club. It's an honor to have Dr. Khalsa here. He is so kind to tell us some of his research, which I think is especially today quite important. Everything anxiety related with current events and the last years. I think is very important. So we are really eager to learn from you. And let me just introduce to you Dr. Khalsa. So he is the Director of Clinical Operations at the Laureate Institute for Brain Research in Tulsa. And he is Associate Professor of Community Medicine, Oxley College of Health Sciences, University of Khalsa. And he did his He did his he got his MD from University of Iowa, Carver College of Medicine, and his PhD in neuroscience of also from the University of Iowa. And before that, he did his bachelor in science and psychology with honors at Stony Brook University. I did the postdoc there. So, he received really many honors and awards. NARSAD Young Investigator Award and Stuart Wolf Scholar Award, to just mention a few. So yeah, it is an honor to have you here, and thanks for taking the time to share your knowledge with us. And yeah, the stage is yours.
Okay, well, thank you, Katerina, for this invitation to participate in a novel science communication discussion format. So I'm looking forward to interacting with people and hearing and hopefully answering questions. I'll do my best. I don't have specific sort of formal remarks prepared given this very conversational format. So, but what I'd like to start with is I'd like you to imagine for a moment that you're visiting a new city and you're walking back through the city to your hotel room. And it's just about twilight, so the light is changing, and you're navigating your way back to your hotel in this new environment, and the street lights are just coming on. And as you're walking, you sort of look up to notice that maybe that the street lights have just turned on, and you notice that that a few steps ahead of you, maybe a dozen or so steps ahead of you, there's a street off to the right, an alleyway, if you will, and there's no lights on in there. And it's getting dark enough now that as you're walking and approaching this alleyway, you have a little bit of trouble discerning exactly what's down there. And this kind of gets you thinking, right? Could there be something negative down there? For example, maybe you see the silhouette of a dumpster or a car or a motorcycle, and maybe you wonder if there's somebody hiding behind it that might wish you harm, might maybe try to mug you. You might think that maybe there's something interesting down there. Maybe there's a park or an unknown landmark, or maybe a shop that carries some unique items that you could bring back home to a relative. So as you kind of are approaching this alleyway and having these thoughts, I want you to think about what kind of physical sensations you might also be experiencing. I think we all have had these kinds of experiences before, encountering this exact type of scenario. And I don't want to speak for everybody, but certainly I think it's reasonable to suggest that your heart might quicken, and you might potentially kind of tense your muscles a little bit in anticipation of the event, either positive or negative. You might notice that your mouth gets a little bit dry. You might notice that your breathing gets a little bit faster or tighter in your chest. And this leaves you with a decision. What do you do? Do you keep walking and do you walk past the alleyway? Do you cross the street to go on the other side and avoid it completely? Or do you go down the alleyway? And each of these decisions comes with an action associated with it that has very specific outcomes and consequences. And of course, in this hypothetical scenario, we don't really know what those consequences are, right? And it's very possible that maybe there's a park on the other side of that dark alleyway, but by avoiding the street, you never get to see the park, and instead you end up bumping into somebody who mugs you, right? This is sort of the inherent ambiguity that we encounter all the time in our environments. So with that kind of explanation, or that sort of example as a background, I want to introduce you to generalized anxiety disorder, which is the most common clinical manifestation of anxiety. It's as defined, it is a excessive uncontrollable anxiety and worry that persists for at least 6 months. And it's perceived, again, it's uncontrollable, right? It's not something that people feel that they can manage. Patients with GAD frequently have not very good responses to standard medications or psychotherapy. They're rather difficult to treat. They affect women twice as much as they affect men. They're associated with a lot of other comorbidities, so depression, substance use disorders, or other anxiety disorders. In fact, it's rather common that the sort of comorbidity is more the rule rather than the exception. In addition, to be diagnosed with a disorder, these individuals have some degree of bodily symptoms. These include things like feeling restless, having a lot of muscle tension, feeling keyed up or on edge, or headaches, or insomnia. And so these are the common kinds of symptoms that a psychiatrist will assess when they're seeing a patient with anxiety, if they're trying to rule out generalized anxiety disorder or GAD. Now, one thing that's sort of a little less known is that patients with GAD often have some degree of heightened perception of other body symptoms. So they frequently report being disturbed by heightened body sensations related to their heartbeat. And in fact, they have been found to present to the emergency department for evaluation of palpitations, sort of a discomfort related to pounding in their chest, at rates that are even with those with panic disorder. So there's about a third of the patients who present to emergency rooms complaining of palpitations or sort of pounding of their heart in their chest or chest pain. About a third of them will actually have a diagnosis related to a psychiatric disorder rather than a diagnosis related to a cardiovascular disorder like a myocardial infarction or heart attack or a heart arrhythmia. So, so I think from that perspective, the perception of physiological arousal that GAD patients have is often somewhat mismatched to their physiological state. This has not been well established in prior studies. There's sort of variable findings that differ depending on whether people were studied in the laboratory or in ambulatory settings. What's clear is that there are abnormalities reported of symptoms related to these so-called interoceptive sensations, or sensations that relate to the perception of signals originating from within the body. But there really hadn't been a lot of studies that looked at this from a physiological and neuroscience perspective. So that's kind of what we set about to do in this particular study. We wanted to look at the neural basis of anxious arousal in GAD. And we wanted to use a very specific experimental protocol, which is one that I've been working with now for almost 15 years, that has a some very distinct advantages if you're trying to understand the neurobiological basis of this of interoception, or of how we perceive the internal state of our body. So What we used is a medication called isoproterenol. Isoproterenol is essentially an adrenaline analog. So what I want to first do is give you a little bit of a background in something called the hypothalamic pituitary adrenal axis, or HPA axis. It's the most common neurobiological pathway that is studied by people who do stress research. So the hypothalamus is in the brain, as is the pituitary gland. And when people are stressed, their brains will send signals from the hypothalamus to the pituitary gland, which then send signals to your adrenal glands, which actually sit down in the body on top of your kidneys, to release stress hormones. And the stress hormone that most people are familiar with and that most people study is cortisol. And part of the reason is that that has a really long range or long term impact on things like cellular gene expression. It can lead to the development and expression of new proteins. It has sort of long-acting properties to it for the most part. Whereas the adrenal hormones, which are actually, so cortisol is released from the adrenal cortex. That's why they call it cortisol. So that's the outside of the adrenal gland. But in the middle, an area known as the adrenal medulla, that's what releases something called epinephrine and norepinephrine, and a common term for them is adrenaline. So in that example that I started with, where you're approaching a dark alleyway and your heart starts to quicken, there are several well-known, well-established physiological mechanisms by which your heart rate might increase. So one of those might be that your brain sends a signal down through your vagus nerve that releases an inhibitory neurotransmitter directly onto the heart, which can slow down your heart rate or quicken it, depending. There's another pathway, and that's sort of thought of as a parasympathetic pathway. There's another pathway where you can release adrenaline directly onto the heart muscle from nerve terminals through a ganglion or a collection of nerve cells called the stellate ganglion. So that's what you might think of as these very rapid millisecond level levels of control over your cardiovascular response. On the other hand, as you're approaching that alleyway, your brain could also get your adrenal glands to squirt out and release more adrenaline into your bloodstream. And that would take about 20 seconds or so to circulate and reach the heart, at which point it could have a direct action on increasing your heart rate and increasing the contractility of your heart, sort of the amount that the heart kicks and squeezes, by directly acting on what are called adrenergic receptors, and a particular subclass called beta adrenergic receptors. So what we used in this study to simulate the effects of adrenaline on the heart and on the body was this drug called isoproterenol. And the reason that we picked it is because it has a very selective action on these beta adrenergic receptors that are in the heart. They're also in the lungs. And they have the added advantage over epinephrine or adrenaline, that the chemical structure of this drug is such that it does not cross the blood-brain barrier very well. So it's a good peripheral way to, or it's a good way to peripherally perturb the cardiovascular system. So we think of this as again, acting at the level of the heart. And then what we were interested in is measuring at the level of perception and at the level of the brain what was happening in the patients. The brief history on isoproterenol is that it was the original asthma medication. It was actually developed because the beta 2, basically it would bronchodilate the lungs, and early asthma patients felt that they could breathe easier during an asthma attack when they got the medication, but they also noticed their heart pounding. So basically what was then developed was a beta 2 selective drug called albuterol that acts only on bronchodilating, or predominantly on bronchodilating the lungs. So if you've ever used an albuterol inhaler, you're not too far away from isoproterenol. But again, in this study, we used isoproterenol because we wanted to have that action on the heart. We wanted to elicit these known, very well-controlled changes in cardiovascular state. Again, the advantage is it acts in the periphery. So we've done neuroimaging studies, several neuroimaging studies in healthy individuals, and found that it indeed, not only in behavioral studies, we've done probably 8 of those. It elicits very reliable increases in the feeling of your heart beating faster and harder, and also changes in your breathing. It does elicit some degree of anxiety, but it doesn't necessarily induce panic attacks. If you use a high enough dose, you can get people to experience some higher levels of panic anxiety, but we've worked to calibrate the dosing so that we give people low levels of the medicine that are tolerable, that increase the perception of heartbeat sensations, and at some levels increase anxiety. And that's, again, part of our interest in understanding the interoceptive basis of anxiety in anxiety disorders. So what we did is we then wanted to understand what's happening in the brains of the patients with GAD. So when we would make their hearts beat faster and stronger, would they feel the sensations to a greater extent, like we would predict? Would they be more anxious, like we would predict? And would their brains show a different response from individuals who were non-anxious? And so our prediction was that a very specific region of the brain called the insular cortex would be hyper responsive in the GAD patients. And that's based on some existing literature that has shown increased insular reactivity under other kinds of anxiety provoking paradigms. And also the fact that in our studies of healthy individuals, which we've done 2 fMRI studies in healthy individuals, we have shown that this stimulation with isoproterenol selectively engages the insular cortex, and particular regions of the insular cortex that have been suggested to be sort of a primary interoceptive cortex, if you will. So we have a somatosensory cortex, right, that has a sensory homunculus, or in other words, different patches of cortex that are dedicated to processing skin sensations from different regions, like the hand or the foot, etc., or the chest. But there really isn't a sensory homunculus, if you will, for interoceptive sensations. So for heartbeat sensations, breathing sensations, gut sensations. That's not really well known. What has been shown time and time again, including in our studies, is that the insular cortex is one of the most commonly involved areas, although there are actually a whole variety of other brain regions that, depending on the type of stimulation, will show responses. So, and we'll get into that in a little bit when I talk about the results. So we were predicting increased insular activation, and we used an approach where we gave 2 different doses of the drug, sort of a low dose, one that we would normally elicit maybe a mild sensation in most, but not all, healthy participants, and then a higher dose that would elicit a clear sensation of the heartbeat in all of the healthy individuals. And then what we did is we recruited our participants and we brought them in for magnetic resonance imaging scanning, fMRI scanning, to look at their brain response during that process. So this particular study was a study of females only. As I mentioned, GAD is twice as common in males and females. This was part of a larger study where we were looking at interoceptive responses to in anorexia nervosa, which is a condition that affects women 10 times as much as it affects men. So because we were focusing only on females for that population, we also were matching the groups. So this is a female-only study. Therefore, one of the limitations is that you can't necessarily extrapolate so easily to males with GAD. So what we did is we brought people in. We actually assessed and consented a total of 125 people, had them go through a very rigorous and careful medical screening protocol, including doing things like getting a 12-lead EKG, getting a family cardiac history, evaluating their health history, evaluating their vital signs, and making sure that we were very confident that the physical risks were minimized. We ended up allocating 73 people, and out of that, in order to report the results of this study, we sort of sub-selected. We had 72 that completed. We did actually have one person who withdrew during the infusions related to a higher level of anxiety, and that was a patient. But out of the 73, 72 completed. And for this analysis, what we did in order to get groups that were evenly matched with respect to age and body mass index, two variables that have been associated with differences in interoception and sort of differences in the perception of heartbeat sensations, we ended up with 29 females with GAD and 29 matched healthy comparison females. So what did we find? The first thing that we looked at is we looked at the basic compositional characteristics. So we looked at, did the groups differ in age or body mass index? They didn't. Did they differ with respect to anxiety symptoms and depression symptoms? And in fact, they did. And that's in the first table of the paper. They also, and this is in a supplementary table, but basically our requirement was that they all had to have generalized anxiety disorder, but they could have certain comorbid conditions. And so the most common comorbid condition was depression, which matches what you see in the clinic. And then they had a number of other anxiety disorders at lower levels of frequency. One thing that the patient group did not have was panic disorder. And that was very much on purpose on our part, because there is a literature that has looked at isoproterenol-induced panic, and panic disorder patients have clearly heightened sensitivity. And what we wanted to do is, because we were focusing on GAD, we really wanted to exclude that as a potential reason for some of the differences that we might see. So none of the patients had panic disorder in this scenario. Whether or not that would, if we had added panic disorder patients, whether that would have led to more people withdrawing from the study is unclear. But again, that's an important feature that we'll come back to for the interpretation of the results. So the first thing that we looked at after we looked at the demographic characteristics was the physiological results. So when we gave people these infusions of isoproterenol or saline, what did their heart rate response look like? And I should add that the kind of infusion we're giving is something called a bolus infusion. So isoproterenol has a very, very rapid half-life. So if you give a bolus dose, that's sort of like giving a 3 milliliter dose, a very small amount that has a response after about 20 seconds of injecting the drug through an intravenous line. Within about 3 or 4 minutes, the person's heart rate is back down to baseline completely. And we've done this in many of our studies. In fact, all of our studies were bolus doses, which allows for repeated dosing so that you can look at the effects of dose stimulation. So one of the advantages is that you can look at the slope of somebody's response to different doses, and then you can calculate this measure called the CD25, or chronotropic dose 25, which is essentially the dose of the drug that would be necessary to increase somebody's heart rate by 25 beats a minute. Just to give you a sense of what the normal heart rate range is it's between 60 beats a minute and 100 beats a minute. So if you ran on a treadmill for a few minutes, you might notice that your heart rate is going up to like maybe 120 or 130 beats a minute, maybe even higher if you're out of shape. So what we do is we use the CD25 to estimate sort of the dose in micrograms that would elicit a particular heart rate response, and that's been associated it's an indirect sort of measure of the beta adrenergic receptor density on the heart muscle itself. Okay, so that's a peripheral sensitivity measure, right? It has nothing to do ostensibly with the brain response. And again, because this drug acts in the periphery, that's been it's been commonly that measure has been commonly interpreted in that way. So what we found in the patients is that the GAD patients actually had lower CD25 values than the healthy comparison patients, meaning that for a given, it would basically take less of the drug to get their hearts to race faster, right? And so we took that as an indication of a peripheral hypersensitivity to stimulation. So the next thing that we wanted to look at was what were their heart rate responses at individual dose levels. And so what we did is we measured heart rate continuously during the scanner. We plotted it out and then we analyzed it across sort of different epochs of the dose response. And basically, when you give isoproterenol, after about 20 seconds, if you've given a good enough dose, you'll see a robust heart rate response that peaks about a minute later and then comes back down to baseline within about a minute or minute and a half. And so we talk about, we've divided that window into sort of peak responses, early recovery responses, and then late recovery responses. And what we found is that the GAD patients showed increased heart rate responses, but it was a selectively increased response that occurred predominantly at the low dose of the drug, the 0.5 microgram dose. And that corresponded on average to a heart rate increase in the healthy subjects of about 7 beats a minute, whereas in the GAD subjects, the heart rate increase was about 13 beats a minute above their baseline. So not necessarily a huge difference, 5 beats a minute on average, but a statistically significant one. And I can tell you, in relation to the existing literature that's non-invasive, that doesn't use pharmacological stressors, usually what they see is about a 2 to 3 beat per minute difference on measures of heart rate change during anxiogenic periods. So this was actually larger than what you would typically see, and certainly physiologically relevant. In addition to that, we looked at perception. So what did people feel? When they're getting these infusions, we deliver this in what's called a double-blind fashion. So the participant does not know the identity of the infusion that they're receiving, and the nurse who's administering the medicine, who's doing the safety monitoring, also does not know exactly what she's giving. So the idea is to try to reduce expectations or giving any cues about what might be coming, so that we can just get as clean of a assessment as possible on what the person's feeling based on sort of flat expectations. So consistent with the heart rate response, what we found was that the patients also showed a selective increase in their ratings of heartbeat and breathing sensations, again, only at this low dose, this one that was in between the saline and the 2 microgram dose. So this was at the 0.5 microgram dose. And the way that we assessed that was twofold. First, what we had our participants doing is they would rate a dial. They would sort of rate their ongoing experience of their heartbeat and breathing sensations continuously using a dial. So when the infusion scan would start, we'd say, okay, here's a dial, and they'd see what the equivalent of a speedometer that went from 0 to 10, and they would be rating in real time every second the intensity of those sensations that they perceived, and the dial would range from 0, which would be their normal or baseline level, kind of none, or normal, all the way up to a 10, which would be the most intensely that they've ever experienced their heartbeat sensations. And so what we found is that during the peak period is when you would typically see the response increase, and the patients, the healthy comparisons went up to a max on average of about a 1.5 out of a 10, at the 0.5 microgram dose. So they were feeling their heartbeat and breathing sensations at a 1.5 out of 10, whereas the patients were feeling it at around a 3 out of 10. So almost twice as high, okay? And then we also had them retrospectively, after each infusion was over, individually rate their heartbeat sensations and their breathing sensations. And we found a similar pattern with those ratings. The breathing sensations tend to be rated less intensely than the heartbeat sensation ratings. That's just based on how the drug works. But so we had this sort of concurrent and retrospective measure. So what this kind of led us to think was that there was maybe some interaction between what's happening in the body, sort of in the cardiovascular and the autonomic nervous system, but also the fact that they're rating these sensations higher, and that's sort of is certainly influenced by central factors, that the possibility that there was sort of an interaction between those two areas, the central nervous system and the autonomic nervous system. So with our imaging approach, we were then able to look at whether there were differences in the brain between the patients and the healthy comparisons. And so again, our prediction was that we were going to see increased responses in the insular cortex in the patients relative to the comparisons. And what we found is that we did, in fact, see increased insula activation with each dose. So an increase at the 0.5 microgram dose, and then again an increase at the 2 microgram dose. But we didn't actually see any group differences between the patients and the comparisons, and that was surprising to us. We were not expecting that. Now, if you remember, I mentioned that there are a variety of areas of the brain that are involved in interoceptive processing, and so I don't have time to sort of do a detailed review of all of them, but certainly the insular cortex, we know, is not the only player here. We know that there are areas that are considered to be involved in prototypical somatosensation, like the somatosensory cortex, primary and secondary, that are often cast as being only sort of related to skin sensation from when the stimulation comes from the outside. But in other studies, we've shown that somatosensory cortex and somatosensory afferents play a role in the heartbeat sensation. But there are other areas of the brain, in the frontal cortex in particular, that also seem to be involved in interoception, and these are in the medial prefrontal cortex for the most part. And so when we looked at our patients, the patient groups versus the healthy comparison group, we actually found that it was in the ventromedial prefrontal cortex where we found group differences in activation. And it was a particular kind of difference. It wasn't an increase in activation in the GAD group. It was actually a blunting response, such that when we gave the isoproterenol, both groups actually showed in opposite to the insular cortex, which showed an increased response, their VMPFCs actually showed a decreased response. So it deactivated in a dose-dependent manner when we gave the isoproterenol. And what we found is that the GAD patients actually, their VMPFC deactivated the most, but it wasn't indiscriminate. It was again a selective occurrence that happened at that 0.5 microgram dose, and in particular during that peak and then the early recovery periods. So we also saw that the VMPFC signal change was highly correlated with the change in heart rate, the change in heartbeat sensation, the change in breathing sensation, and to a lesser extent, that in our case didn't survive correction for multiple comparisons. To a lesser extent, it also correlated with anxiety. So again, there's this sort of multi-level association between what's happening in the heart, what's happening with sensation, and what's happening within the brain. And on top of it, as we predicted, the patients experience significantly more anxiety. So we use the same anxiety rating scale from 0 to 10. So 10 being the most ever, 0 being none or their normal level of anxiety at baseline. And there, the patients actually had reported higher anxiety than the healthy comparisons at both the 0.5 and the 2 microgram dose. So the healthy comparisons anxiety rating was about a 1 out of 10 for the medium dose, and then a 2 out of 10 for the high dose, whereas the patients were at a 2 and then a 4. So almost a doubling in each case. So, so what does all this mean? I'll try to do a brief summary and then open it up for discussion so that perhaps more of the interpretation might come out in relation to your interests. So we think that this study provides evidence of kind of two things. One is that there's an impairment of so-called top-down regulation. In other words, the VMPFC, the blunting of the VMPFC response shows sort of an impaired ability to constrain or regulate cardiovascular arousal in GAD. And this is a brain area I didn't mention, but this is a brain area that shows a lot of activation in a variety of different contexts. Not all of them having to do with interoception, but a lot of them having to do with fear learning, safety learning, self-evaluation, emotion processing, personality traits. It's called it's really an area of the cortex that's called a polymodal association cortex, meaning it has many different functions, and so pinning any one down on one spot in the brain is kind of ludicrous. At the same time, when people have studied the function of this area from different perspectives, they've seen consistent responses in a variety of different conditions, and one of them is this notion of the VMPFC playing a visceromotor regulatory role. And in fact, the VMPFC is very tightly anatomically connected with the insular cortex, and so one possibility that we thought is that, well, since we're activating the insular cortex pretty decently in both groups, even though we're not showing differences there, maybe there's some kind of dysregulation that's existing between the connection of activity, the functional activity in the between the VMPFC and the insula. We've seen evidence of that in this same sample in a different study that is at the level of a preprint right now. It's not has not completed the peer review process, but that sort of was some of our thinking. The other thing that's relevant about the VMPFC is that that there's a movement to consider the role of brain circuitry in anxiety that goes beyond the amygdala, which if you've ever heard about the neurobiology of anxiety, probably the first thing you might think is amygdala equals anxiety. It's kind of like when people say insula equals interoception, and of course neither of these is true. The amygdala is actually involved in interoception as well, and the insula is involved in a lot of other things, including language of all functions. So, but getting back to anxiety, some of the current thinking is that there are these higher order circuits that are cortical that have connections to the amygdala and have connections to the insula that play a role in more evaluative and cognitive aspects, subjective aspects of fear, and the VMPFC is a prime player in that. So that was kind of some of the way that we thought about this. One point that I'll make, and we may get back to this, is that I've talked about this stimulation as occurring in a sort of bottom-up manner, where the drug works on the heart in the periphery and then elicits this subjective response and a brain response. But I also talked about the VMPFC as a visceromotor regulatory organ that can regulate insula activity, regulate amygdala activity, and then of course there's a whole downstream circuit that is well established in fear, including the HPA axis, but also brainstem structures like the periaqueductal gray that have a very orchestrated patterned response when fear is triggered, and this is a evolutionarily conserved response. And so the idea, essentially, of what I'm bringing up is that of a loop, and it kind of a brain-body feedback loop is a very general way of describing this. And we've put input into the system at the level of the heart, and we've seen these very consistent differences across all of these levels of measurement. On the other hand, pinpointing exactly which is the key controller or what's the critical node within this feedback loop is something that we're unable to do with this study, because we don't have that ability to establish causality at individual points along the way. This is a unique study. This is actually the first time that somebody's directly modulated interoceptive signals related to fear circuitry in clinically anxious individuals. So it represents a significant advance. It's a tricky study to do. As you could imagine, you need a multidisciplinary collaborative team across sort of branches of medicine and across the fields of neuroscience. One thing that I think it raises the possibility of is future clinical applications. So while we can't say definitively that the VMPFC is the key node, it could also be there could be peripheral differences in sensitivity that are driving fear responses. So in other words, going back to the original metaphor I started with, or scenario, where you're walking up to the dark alleyway, I can't say for sure that that the person whose heart races a little bit more and who feels more anxious, that's happening because they have more beta adrenergic receptors in their heart, or that that's because they have a reduced ability of their VMPFC to constrain those arousal signals, or a combination of the two. On the other hand, I do think that it suggests that future clinical applications could include studies that would aim to focus on different aspects of that loop to then try to get information about the causal drivers. So one way to do this within the central nervous system would be to target ventromedial prefrontal cortex responses using neuromodulation techniques. And the two that we highlighted in the paper were real-time fMRI neurofeedback, where a person gets a visual image on a screen of their VMPFC activity while they're in the scanner, and they learn various techniques to try to control the signal. So it's not biofeedback, it's neurofeedback, or you could think of it as kind of an extreme application of biofeedback, with the bio being their brain signal on this point. Another option would be to just sort of more directly take charge and use a device to intervene directly on neurons in the VMPFC. And of course, you can't do this invasively in the vast majority of people, but there are non-invasive neuromodulation tools that exist, as well as ones on the horizon. And the one that we focused on, no pun intended, was transcranial focused ultrasound, or TFUS. And this is different from transcranial magnetic stimulation, which has a very broad focal beam and cannot penetrate very deep into the brain. The VMPFC is pretty deep in the brain, and it's a midline structure, so there's a lot of tissue that the TMS signal would have to penetrate, and it's not been shown to be very good at that. Transcranial focused ultrasound, on the other hand, is actually great at focally targeting deep structures in the brain, and it uses ultrasound waves to do that. That's an early technology that's getting some increased attention in the field of psychiatry and neuromodulation. I think those are some of the potential next steps with this work. So with that, I'll just end on the limitations of the study. This study, there's a sort of an increasing movement in the neuroimaging community to argue that you need to have really large samples, and 29 subjects per group by modern standards is no longer a large study. If this was done 10 years ago or 15 years ago, it would have been considered a pretty reasonably large sample size. On the other hand, when you have the advantage of focally modulating a system the way that we are with this medicine, this is actually a particular type of study called an experimental medicine study. When you can causally manipulate signals in a known way, I think you have a real advantage, and oftentimes you don't need to have as large of a sample as you do for other kinds of studies. As I mentioned before, this is a female-only sample, so we can't really extrapolate well to males. We did allow people to use into the study who were taking who were stably medicated for their GAD. There were only 6 of the subjects out of 29 that were medicated. We did additional analyses without those subjects to see whether that had an effect, and we really saw no real major differences in our results. So I think the advantage, on the other hand, when you have a causal manipulation in this experimental therapeutic framework, I do think it's important to be able to study patients that are clinically representative. I mentioned that comorbidity is the rule rather than the exception. Certainly medication is very common for GAD patients, and so I like to think that the sample that we studied is pretty clinically representative of females with GAD. So I'll leave it at that and take your questions.
Yeah, thank you so much for this great introduction, for the overview of your work. It was really very very like broad, and I think it was great for our audience. And so yeah, let's start with questions. Please flash your mics, raise your hands. I'm sorry, and go ahead. Yes, Christopher, go ahead with your question.
Okay. My gosh, I have so many questions for you, doctor, but I'll try to keep it brief. Um, you were, I know, I saw your study. There was 58 women. So, did you say that you couldn't discern if that would be beneficial for if it was just primarily for women that had GAD or men as well?
Well, we didn't study males with GAD, and so in terms of making our conclusions, we kind of have to constrain them to the sample that we tested. I mean, if you were to ask me what would I predict with if we did a study that was only males with GAD, I wouldn't have predictions that were different. I would actually think the same thing. One of the challenges in the literature on GAD, particularly in the neuroimaging literature, when you look at the studies that are out there, they tend to be in female enriched. In other words, let's say there's a study that has 30, or actually, the more commonly they're in the low 20s, so 23 GAD participants. It may be that only like 3 or 4 of those participants are males, and I mentioned that the ratio of the disorder is 2 to 1. So in that scenario, if you really want to be able to have an equal understanding of sex effects, you probably would want to have evenly sampled males and females in the study and then have a large enough sampling that you could then break those into subgroups. So let's say 60 GAD patients, 30 of whom were males, 30 who were females, and then another 60 healthy comparisons. The challenge, of course, is that those are really large sample sizes for the kind of work that I've described to you, which took over 5 years to collect the data. And that's not even including sort of writing the grants. In the literature, for whatever reason, there just tend not to be a lot of males in these studies. So what I've seen is that oftentimes the researchers will make a conclusion about GAD in general without addressing sex effects, even though their sample may not necessarily have that many males that would allow for a fair interrogation of the question. Does that help?
Mm-hmm. That makes perfect sense because we don't want to reveal ourselves, right? Does your study reveal anything about how PTSD? Okay, so I'm clinically diagnosed. I have PTSD, general anxiety disorder, depression, and pre-hypertension as well. And because of just my genetically, that's um, what I was predisposed to. Would that be a good or how can I frame it? Um, would I be a client or I mean, what could I potentially go down that path? Um, I know you can't say that 100%, but in general.
Yeah, well, thank you for sharing that information. I can tell you that there were participants in the study who had PTSD. I think it was on the order of maybe a quarter of the sample, and there were, based on the percentages, there were many individuals who had all of the disorders that you listed. Not all of, none of them had hypertension because that was an exclusion criteria for the study. Um, in terms of relating the results to PTSD, it's an area that I'd be interested in pursuing because one of the diagnostic features of PTSD is heightened autonomic arousal. So people who are not only vigilant with their thoughts, but they're very vigilant about what's going on in their bodies. And this can happen after a single trauma. It can happen after repeated traumas. Um, and whether that is because the traumas themselves are exerting their effects through primarily the central nervous system or through sort of a combination of the peripheral and central nervous system. As I mentioned, a lot of stress research is focused on looking at cortisol and the effects of cortisol gene expression, cortisol-induced gene expression changes in the brain, right? And there are a variety of differences that have been found, oftentimes more commonly in females, it turns out. But this is an area that I think is really unexplored territory from the standpoint of the interoceptive sensations that we're
Okay.
inducing.
Oh,
So I can't say for sure, but I can tell you that it's definitely an area that I'd be interested in doing further work in.
okay.
Do you mind if I go ahead with my
Just
question?
one more. Just one more, real quick. It's you spoke about the prefrontal cortex, right? Um, and the intuition is what I was thinking. And when you were sharing as well, about that hair standing off the back of the neck, and also the instinct is the I know I'm sorry, doctor. I just call it Abdullah of the God, just from Mr. Deeds. That's just a little funny thing because that's the only way I know it's not 100%, you know, what it's called. Okay. But I think you know what I'm talking about. Um, and so how do we differentiate the two as well? And also, um, the breath, oh my gosh, my breath gets really tight and, there's a lot of tension and all kind of stuff that happens in my body. And I've been trying to do things like meditation, groundwork, and as well as within my primary care physician and my LMT as well. But how can I add a different layer to, you know, so it's not permanent?
Yeah, that's the big question, right? How do we uh, provide therapies that deliver enduring change, enduring improvements in symptoms, right? This is the sort of fundamental nature of psychiatric disorders is that we take symptoms and we collect them into what we see as patterns, oftentimes on the physician doing that, right? Somebody who researches and treats patients with a particular condition and says, oh, I see this pattern of symptoms. Let's call it post-traumatic stress disorder. So symptoms themselves are things that person feels, right? They're sensations or thoughts that are bothersome, usually, and to the point where that discomfort causes the individual or others around them to bring them to a provider for care. So, you know, we have a long ways to go before we have permanent solutions in terms of treatment for PTSD. Medications can help some. For some people, they are a long-term solution. For some people, psychotherapy can be a long-term solution. For some people, they need multiple modalities combined. I'm not able to point at this point to a single option or combination option that has that sort of defined territory. Um, but I think what I'd like to say is that the approach that I'm taking with this research that is very physiologically grounded is one that is aimed at trying to understand the physiological and neurological basis of the symptoms that people such as yourself are experiencing. So how is it that the body and the brain together are generating this discomfort that is that maybe if we can access those underlying mechanisms and tweak them, we could attenuate the symptoms. And ultimately, if the discomfort goes away, if there's no impairment of somebody's function, that would be what one of the ingredients of the definition of a long-term cure is not a good word, but a long-term outcome that's beneficial, right? I'm not able to sort of point to specific things at this point, but that's sort of I think the advantage of this current approach is that we're at least looking under the hood, right? We're looking at the physiology, we're looking at the brain. There are, of course, other social, economic, and cultural factors that maintain, reinforce, and can sometimes even be a causative for disorders. And so I don't want to also tell you that I think the answer is all in biology, but these are some of the most complex conditions that are encountered within medicine. And so a simple solution is probably not going to be there. Olu, you had a question?
Thank you,
Yeah,
doctor.
sorry, I'm gonna have to take off in a couple of minutes for another meeting, but this is really great work, and I know it's not easy to do, so I wanted to commend you and applaud this excellent paper. I just had a couple questions, one specific to the paper and one more general. The one specific to the paper is that you've got these regions that you identified as associated with these autonomic changes, like with sort of your most significant finding in the VMPFC. I was wondering if, and you were saying that you're not quite sure, sort of, that all of the sort of activation and the interaction between these brain regions and the autonomic nervous system are sort of in this loop. But I was wondering if you also looked at connectivity between your significant regions of interest and additionally affective connectivity to see if there was maybe a causal node, at least in the brain, related to some of your findings. So that's the specific question, and then I have a follow-up, more general question.
Yeah, that's a great question. So we're trying to think about ways of doing effective connectivity that that would fit our data structure. Part of the challenge is that turns out the imaging analysis is pretty simple because we only have 2 trials of each dose, and so we're doing in to do some of these kinds of connectivity analyses. Really, what you want to have, as far as I understand, is multiple trials or but the physiological response that we're inducing carries out over like a minute to a minute and a half. So we end up using a block design analysis, and with only 2 trials per condition, uh, I'm a little uncertain that we actually are going to have enough power for something as nuanced as an effective connectivity analysis. I do have a student who's working on that, and we actually have uh, some data in other conditions, neurological conditions, in fact, where people who have known focal brain injury, where we are going to try to look at a single subject level, whether we can see differences in effective connectivity, maybe more prominently when a particular region of the brain is focally damaged, right? Like not no damage that we induce, just these are patients who had a naturally acquired brain injury. So it's a great question, and we haven't really moved far ahead. The most that we've done in terms of connectivity is a resting state functional connectivity. That's a preprint I can send you if you're interested. And that one was using sort of Bayesian analyses as well as the standard FC. And the Bayesian analysis is actually pretty cool because it allows you a lot more flexibility and ability to detect differences that sometimes the standard kind of multiplicity corrections with standard connectivity, are a bit challenging. So.
Yeah, yeah, please do. I would be interested. And then my more general question just comes from my clinical experience of um, treating patients with GAD that also have chronic pain, and often very difficult to treat chronic pain issues, typically musculoskeletal pain. And I was wondering if you can comment on how your work might relate to that sort of clinical experience.
Yeah. Sure. I'll also add, so I'll send you the preprint, but if you have specific thoughts about particular effective connectivity techniques or papers, just let me know because I'll pass them along to my student. So the thing about pain, so it's interesting to me that GAD patients frequently have, they have muscle aches, they have headaches, and it doesn't seem to get a lot of attention in the literature, and sort of I haven't done studies specifically looking at the chronic pain overlap. In terms of therapeutic outcomes, one thing that we are doing is looking at interventions that both appear to modulate interoceptive experience and acute pain in a therapeutic or positive manner. So, and this will require a bit of a change in mindset related to what I've already spoken about. And that is this novel behavioral intervention called flotation therapy. This is something that, or float tanks or sensory deprivation tanks. If you Google that, you'll find a bunch of stuff. There's an annual float conference that has some nice videos from the conference that you can learn about some of the research. But there, it's an environment where you're kind of attenuating the outside world. If you think about the isoproterenol, we're kind of boosting the internal world with the drug and increasing anxiety to some extent. With flotation therapy, you're attenuating the outside world. People are in this shallow pool that has a lot of salt water in it, bath salt, so it doesn't prune your skin, and they're kind of shut off from the outside world. So the lights are off. It's a sound attenuated chamber, and they're floating on the water, so they don't have to hold their breath or tense any muscles to just kind of relax and stay afloat. There's more salt in the water than the Dead Sea. So one of the interesting findings from that technique is that, first of all, there are short-term pain reductions reported by patients. And then the other thing is that people report feeling interoceptive sensations like their heartbeat and their breath stronger. And we've seen that in patients with GAD who have comorbid pain disorders, as well as GAD patients without comorbid pain disorders. But when you just look at their acute pain rating on a visual analog scale from pre to post float, they actually experience significant attenuation. So I'm not saying that means you should then go and recommend floating for all your patients, but I do think that that's something that, as a non-pharmacologic alternative, and certainly it's less likely, much less harmful than opioid medications. To sort of explore. I think for other things like fibromyalgia, it could be interesting too.
Hey,
Sorry, Mark, go ahead. Oh,
Yeah,
Dr.
I was
Olu,
just
if
going to
you
say
want to
very
follow
cool and
up.
thank you very much. I think Dr. Rasnick had a question.
Yeah, thanks,
and
Olu.
I'm sorry I was only able to give the paper a desultory scan, but this relates to the physiology. So you're giving the patients isoproterenol. Now, when they would normally have a sympathetic episode, they'd be getting epinephrine. And although clearly I agree with you, that's primarily beta adrenergic, there is going to be some alpha adrenergic interaction. And I'm just wondering whether there might be a difference between epinephrine and isoproterenol challenge.
Yeah, likely there would be. I mean, certainly you would see blood pressure differences. So we tend to see actually decreases or minimal changes in diastolic blood pressure with isoproterenol. That's actually one of the reasons it's commonly used for cardiac stress tests, is because it will increase contractility and increase systolic blood pressure, but the reduction in diastolic will kind of is sort of safer for the cardiovascular risk. So yeah, we haven't done that. We certainly it's possible that it could be done. I would need to have a strong enough rationale. I think the reason, I mean, it would be the sort of thing that if you had clear hypotheses about alpha adrenergic receptors, and certainly alpha antagonists and are something that's used, right, in treatment of PTSD. There's central effects, of course, of the alpha antagonism. So it's kind of you know, there could be an interesting story there, but I'm not sure that that's going to be an area that I'll be moving
No,
into
I understand.
anytime
I
soon.
guess what all I'm trying to say is that stress would really be epinephrine and not isoproterenol. And I'm just the idea is, could there be a different response pattern when we're dealing with the actual autonomic um, messenger of stress?
Yeah, I think it's possible. I think it just depends on which aspect of the processing you're talking about. If you're talking about signaling within the autonomic nervous system, or you're talking about symptoms, there might be differences in symptoms, but there might not be, even with existing differences in autonomic reactivity. So um, hard to know.
Thanks.
Yeah, are there any other questions? I know we went a little bit over time, so yeah, if there's maybe another question, a last one, we can go ahead maybe, but if not, I don't want to stretch too much Dr. Khalsa's patience. And yeah, Dr. Mariam, please go.
Oh, not a question. I just wanted to say thank you to Dr. Khalsa for his presentation. This was a really interesting paper, and I look forward to hearing more of your research. So thank you for being here today.
Yeah,
Thank you for having me.
the same here. Yeah, if you come back anytime with updates, or maybe your student would like to come and present um, the preprint you mentioned, that would be great. So yeah, please come back, and yeah, come back with updates. Christopher, thank you for asking interesting questions. Dr. Olo had to leave, but everyone in the audience, thank you for coming. And yeah, I hope you join the club. We have more interesting researchers coming here to present. We had actually a very interesting researcher also related to mental health disorders this week. So yeah, I hope you have time to join us again. And yeah, thank you so much.
Thank you, Katerina, for the invitation, and thank you all for attending and for your very thoughtful and insightful questions. I'll certainly be tuning into more of this society's activities.
Doctor, before we leave, is there any studies about, I'm not clinically diagnosed with CTE, but I've had multiple concussions. Does that come into play at all?
There are none that come to my mind right now.
Okay, that was my final question.
Yeah, thank you so much, everyone. I'll see you back, or I hear you back tomorrow. It's a little bit of a different topic tomorrow, and over the weekend we have like some climate change, innovation updates, and a company that is doing really interesting solar power, um, uh, linking with agriculture. That's on Sunday. Tomorrow we'll talk about privacy issues with new tech. Google doesn't need nowadays the camera anymore to detect your behavior. They have like other sensors now in their technology. Yeah, so we will discuss that, and then next week we will have some more very interesting guest speakers. So we had to move the Friday room about the clinical study with microdosing with LSD in healthy subjects that is moved to next Thursday in the evening at 9. And then we have Dr. Galitano on Wednesday. She will come at 10 p.m. talking about sleep deprivation, upregulate serotonin receptor effects. And Dr. Schwartz he will come and present on Wednesday at 10 a.m. X-ray computational ghost fluorescence mapping. But it's a really cool new technology that he and his team developed. And then on Tuesday we will have Dr. Ballone talking about autism driven by gene environment interactions. So yeah, thank you all for coming, and I'm looking forward to more rooms. And have a great day, evening, morning, wherever you are around the world. And thank you.